want you to not know that. Alright, so basically a gluteal fold separates what we call our buttocks to our thigh. Then of course you have the butt crack, the inner gluteal cleft, plumber's crack there. When we look at the gluteal muscles, all of these are going to be muscles that act upon the hip. When we talk about the actions of the hip, abduction, adduction, circumduction, they help with all of them, but we're going to focus more on looking at how they help to rotate, external, internal rotation. We're going to look at different groups of them, and then of course flex and extend. So we kind of already went through the actions of the hip, but the gluteal muscles are the muscles that perform those actions. So we get these nice long lists that y'all love of muscle groups. So you have a superficial group and then you have a deep group. The superficial group is the larger muscles, gluteus maximus, medius, minimus. I'll show you their similarities and kind of how they're set up. But then we have a bunch of really short lateral rotators. So they classify all these as lateral rotators. Some of them do slightly other, help with another action like a lot of muscles do. But I won't read through the list. We're going to go through and I'll show you how to divide these up. One of the good things about the gluteal region in both of these groups, the superficial and deep, is that they name the nerve that goes to the muscle is named the same as the muscle. I always like it when they do that. It helps me to remember it. So the first one up is gluteus maximus. There's a lot of those out there. There's a lot of people like that, right? Not a gluteus. Some are just minimum, medius, but you know the person in your life that's the gluteus maximus. It originates off the iliac crest and the sacrum up here, and then it's going to insert officially just like the deltoid. It has a tuberosity that it can connect to, but it ties mostly into the tensor fasciolae, the most lateral structure of the leg, our iliotibial band, as it continues down to go below the knee. So when we look at gluteus maximus, it's going to help extend the thigh at the hip, to bring it backwards posteriorly, and then it can help to laterally rotate the thigh. Remember, we're always talking about the long axis, down the length of the femur and how it's going to turn. The gluteus maximus gets inferior gluteal nerve, which this is one of those things to pick up on, because if you don't ever study muscles, the largest gluteal muscle we have gets the inferior gluteal nerve innervation. But the other two that are smaller than that one get superior gluteal nerve. Just, once again, I wasn't there to name them, so I would not have done that. Gluteus medius, when you look, we'll just compare these two slides real quick. If we go back and forth between gluteus medius and minimus, nothing changes. Besides the actual muscle there, if you look at the muscle for a second, it's going to go back and forth. And then if you look at the name, that's it. So the origin and insertion is exactly the same, and the actions are going to be exactly the same. I want you to read through this action of medius. Entire muscle abducts the thigh at the hip. The anterior fibers flex and immediately rotate. Posterior fibers extend and laterally rotate. What does that sound like? What other muscle group we just tested on them does that sound like? The deltoid. So medius and minimus actions are pretty much the same as like the deltoid. And both of them are superior gluteal nerve. Alright, and then we get to the short lateral rotators. Piriformis. Piriformis is actually a pretty important muscle in regards to people's complaints, because it's another area that we said gets entrapped. Especially when you sit at a desk all day, or you drive from here to Fort Benning 13 hours, or however far it is, and that gets tight, because the piriformis is the only muscle here of the gluteal region that originates. So if I want to take this picture, and this is our spine coming down, and then we have our sacrum and coccyx. Here's our ilium on the side there. Well, this muscle actually originates inside of the pelvic cavity and then it inserts into the greater trochanter. So because it's coming out of that opening is actually the greater sciatic foramen, and we know that the sciatic nerve comes out of there also. And so it's an area where you can get some pressure and impingement upon that sciatic nerve. You start to develop some like sciatic symptoms. So its job, though, officially is to laterally rotate and abduct the hip. And its innervation, like I said, a lot of these are just going to be named for the nerve. So the piriformis nerve, or nerve to the piriformis, innervates piriformis. I separate the next kind of groups of these short lateral rotators into a couple of different sections. I like to draw a line. There's piriformis above that, and it's going to have to be a curvy line, but then I like to draw another line here. And what I'm doing, slowly but surely, is separating. You notice there's two muscles in between those two lines, and then down here there's two muscles. The reason I'm doing that is they're separate muscles, but when they named the nerve, they put both of the names of the muscles in the name of the nerve. Right, so if we pay attention, say, well, here's our superior gemellus, and look at its innervation, you'll say, well, that's the nerve to superior gemellus, but they also say, well, that's the obturator internus. And that's because obturator internus is here, and superior gemellus is here. We just have all of our own muscle slides, but that, I'm just trying to explain so you can catch the innervation. So the origin of the superior gemellus is off the ischial spine. Is going to insert into the greater trochanter, like a lot of these will. And it's going to help laterally rotate abductor thigh. So a lot of these, they're all called short lateral rotators, but because of the way they're set up, it's seen that they can help with abduction. So you'll always see abduction, but it's a minor assist there with abduction. Here's inferior gemellus. When we look at inferior gemellus, it's down here. Comes off of the ischial tuberosity, inserts to the greater trochanter, rotates the thigh laterally, and also helps to abduct. Once again, a lot of these are going to have the same actions. Nerve to quadratus femoris, inferior gemellus. Then we have quadratus femoris, which is this muscle we find here. Ischial tuberosity to the inner trochanteric crest. Remember, on the front of the femur, on the posterior side of the femur, it's a crest. When we look at the anterior side of the femur, between the greater and lesser trochanter, it is an inner trochanteric line. And it helps to rotate the hip laterally. Doesn't have a lot to do with abduction, and partially that's because it's not inserting up high, it's actually inserting down lower between these two trochanters. So it doesn't give it the great ability to help abduct. So it's kind of an angle, a measurement angle thing of how you use it. And it's nerve to quadratus femoris and inferior gemellus. And obturator internus, I know it seems like there's a lot of these, and I'm just kind of droning through them, but we just got to get through them, then we can look at them on charts. Obturator internus is covering, this is the obturator foramen that we saw when we discussed, the difference in male and female pelvises. And you have these openings, these obturator foramens, and you have a muscle that lies on each side of that obturator foramen. This one's going to originate there and insert into the greater trochanter, rotates the thigh laterally, helps to abduct it, and then it's nerve to obturator internus and superior gemellus. Then our last one here, obturator externus. Externus is on the anterior side of the obturator foramen here. Question? Something going around, everybody sneezing. I have to cancel class and it keeps up. I'm kidding. You have a dotted line because it goes back behind. Rotates the thigh laterally, helps abduct. You have to always visualize how things are there. When you say obturator externus, that one covers the obturator foramen on the outside. So anteriorly, it's external to the interior side of the pelvis. So it's out here. And it's going behind the femur. So that's how it helps to laterally rotate. That's the dotted line that you see here. And this one's just obturator nerve. Alright, I realize those are kind of some boring muscles. When you look at these overlaps and just pull out a picture, I only boxed a few things here to show, because we're talking about the gluteals right now. So you have your iliac crest, and then you have the gluteal aponeurosis, the muscle, and then all of that is going to tie into the iliotibial vein as it comes down. If you go to another view, we can kind of see how our gluteus maximus overlies. So deep to this, and on the next picture I'll show you, deep to this are the short lateral rotators. And then you have your hamstrings that go on down. Just trying to give you a visual before we peel that away. And hopefully the specimen I like for this is up here when we do the lab next week, because you can actually see all these rotators, the lateral rotators of the hip. It gets kind of confusing. It's not one that I like to use for diagramming because it's one thing to study the muscles, it's another to key in on identifying something on it. So the short lateral rotators, I don't often ask you, like in this picture, to identify them, but it's picking out the key things. Like one of the key things we just talked about was the piriformis. And that's an important one because we're going to talk about piriformis syndrome. And you will see people with piriformis syndrome. So, but I would not worry about labeling this picture. Oh yeah, I kind of got ahead yesterday and I talked a little bit about blood supply to the hip. And I did pull up the video so I could show you and introduce you, but we'll get to that in a second. Blood supply to the hip joint. As confusing as it looks when you pull it up on a slide, it's really not. It's you should break these down and say, well, there's the femoral artery. Right? We had our common iliac, our external, internal iliac, remembering that our external iliac became the femoral artery once it crossed the linguinal ligament. And so that's going to supply all the anterior compartments of the thighs. The confusing part is when I add all this other stuff in here. And all I'm saying, all you got to take out of that is there are, remember at the shoulder around the humerus, we had this, you studied the axillary artery. We had circumflex arteries that went around the head. The same thing happens here, and that's all I'm really telling you on there. And it supplies the head and the neck. The reason I left those in there that way is because the obturator artery gets a little more significance, because not only does it supply the medial compartment of the thigh with its blood supply, but it's what provides the blood supply to the head of the femur, which we're going to talk about what happens, like we did yesterday, about what happens when you disrupt the ligament that has the artery to the head of the femur. And then the gluteal arteries that go to those muscles are branches of the internal iliac. Right, so that's going to hit all of our gluteal muscles, tensor fasciae lata, we haven't talked about yet, and then all of those short lateral rotators. And so you can kind of just group that. Think about your arterial kind of cascade. You had your common iliac, then we have our internal iliac that goes to the pelvis region and the gluteal muscles, and then we have our external iliac that becomes the femoral. The femoral goes to the anterior compartment of the thigh. So that's how you break them down, but I want to focus for a second on what happens when you disrupt this, and we'll have a little fun today, is, once again, This is the obturator artery. If you go in to find this book in Netters where I have obturator artery there, because most people you ask them, what's the blood supply to the head of the hip? They'll say the obturator artery. Don't write this down. It's actually the acetabular branch of the obturator artery. That's just for those of you who studied it before. But for us, it's just obturator artery. It helps to simplify things. If you, once again, I know I'm repeating myself, if you damage this, the hip injury, basically this area of the femoral head is going to necrose. And you're not going to be walking around on that. It's going to have to be fixed. This could happen in an auto wreck, whether you dislocate it or not, shearing forces. It's a scary thing to think of if you have a big accident because, like I said yesterday, if that happens and you don't know, I damaged my hip really hurts real bad. I got in an accident, I did something to it, and he fast roped, and or actually, if you're held like I did once, they made you go down with a full load. I ain't never doing that again. Y'all have fun with that. I only wanted to get to the ground when you have all the weight on you. I wasn't any good at it. That's why.
I was going to ask you, essentially be like an airborne injury?
Oh yeah. I often wondered about a guy who, doing Air Force Base, I went out to watch the air show when I was in phase 2 for PA school, and I'm watching them, they dropped them, and I'm like, well, this is not good, because a lot of them were headed right towards the tarmac, and I watched this one guy come in fast, I saw him bounce. Anybody, all you jumpers ever bounce off your, bounce like 3 feet in the air after he hit. I'm like, oh my gosh. I got a video for you, and as I set it up, I got a story that makes myself sound like an idiot once again, but we were all idiots at one point. But I know this. I am right. This applies to y'all too. You ready for a deep thought? I am right where I need to be because of where I've been. Good or bad? Tell me what he talking about. Okay. Pull up Super Bowl and quit talking. No, the story is, I was an E1 or E2 medic in Hawaii, Schofield Barracks, Hawaii. We're up on the East Range. They sent us up there, said, hey, take the ambulance, go up there and sit. There's going to be some guys who jump out of planes, and they're going to come land, and they just need a medic on site. We were sitting in the ambulance. I don't know if I was reading a book at the time or buying a Game Boy. Back then they had Game Boys. That's hilarious. I know. So we're playing Game Boy or something. Yeah. I hear somebody yelling. I see some guy waving. But and a few seconds before, we were both sitting there, me and this other private. He may have been an E3, so he's my boss. And, you're sitting there, you kind of get, I got stung by a bee sitting there. It was a great day. But I see these guys coming. I remember him saying something like, that guy's coming down fast. Anyway, this dude's yelling. I'm about to make myself sound really dumb, but so you know you don't know, I guess. Maybe. And he's yelling something. And what he's yelling, and he finally, when he gets about 20 feet from me as he's running over here, he finally changes what he's yelling and says, medic! He was yelling corpsman the whole time. I'm like, what is he saying? I don't know what this guy wants. End of the story. They got mad at me. This guy came down and fractured both his tibia and fibula. And I went down and shoot the cords. I'm not a jumper. I don't jump out of plane. But they were all wrapped around him, and I could not get it off of him. So I just cut him. I left him in his boot to get him out of there, splintered up, and I cut all the cords. And they were pissed. They were pissed. Yeah. Y'all would be pissed too?
The riggers are pissed. The riggers are pissed.
What am I going to sit there and do it like a rope at home, that you don't know how to wind her? The dude was screaming. I'm like, shut up, man. he was bad. He was bad. You're wondering why we didn't take the boot off and look at it anymore. You already know it's broken. All you got to do is get down from each range. There's no reason to stay there and mess around with this. That wasn't terrible, maybe. All right, here we go.
Are you trying to put it back into place?
No. I didn't know what a corpsman was. You think I knew how to put it back in place? All right, so sound to muted here. I'm gonna play. It's a little long for class, and it shows a lot of highlights. But the point of it is to watch when towards the end when he grasps onto him, and he'll talk about Bo Jackson talk about what he felt on that. If you want to see the rest of it, you got to go and look at it. 30 for 30. If you ever want to hear about Bo Jackson's injury, watch 30 for 30. It's an amazing documentary, but it's mandatory, at least if you're from Texas like me, it's mandatory after you watch that one to go watch the Brian Bosworth one.
Yes.
You got to watch them back to back. So, here we go. That's Deion Sanders if you didn't know. I gotta get the sound out.
That's about as embarrassing a thing as can happen to you as an even player.
Great video.
There are things about him that simply you know you can't duplicate. The Bo Jackson, the size, the speed, the power. I mean, he had all of that.
When you look at Bo Jackson compete, there was something obvious about his greatness.
And joining me now is the ESPN Sports Science greatest athlete of all time, Mr. Bo Jackson.
Well, the center field, Deion Sanders going back to the wall, and it is gone. Bo Jackson overs.
What made Bo a great athlete? Where do you start?
To achieve that level of greatness and sustain it in one sport, how you gonna have it to give to another?
In Seattle, Washington, it'll be a noisy and semi crowd for tonight's meeting of the Seattle Seahawks and the Los Angeles Raiders. He gets by for a one-on-one, and Jackson just steps him into the end zone.
You can't tell me that Bo Jackson didn't arrive on Earth naked in a blue ball of light.
You can't tell me that.
All-star level in two professional sports. This is arguably the greatest athlete in the history of pro sports. He's got world-class speed and enormous strength, coupled with surprisingly supple coordination.
Jackson was baseball and football, and he did football.
Living on the American League's top vote winner of 1989,
Oh, down there, that's a pretty interesting hobby he has for his vacation when the baseball ends. He winds up playing football.
the dude hit 32 homers and was an all-star for the Warriors, and he was a Pro Bowl running back.
1989 Major League Baseball All-Star Game led off the game with a monster homer off Rick Russell named Dan Gates. He clocked 4.1240. Still, the fastest 40 ever recorded in combine history.
We may be watching history tonight.
What are little boys' dreams made of? Touchdown runs, home runs, and all-star game. What do you call a kid who does both? His mother called him Vincent Edward Jackson, but America knows him as Bo Jackson.
Combination of speed and power.
There's nothing overrated about Bo Jackson. It looked like he got crushed. He slid down and grabbed my legs. And when he grabbed, I pulled my left leg free. And running as fast as I was, he clamped down on my right leg and was able to hold onto my right leg and stop me in my tracks. I was running with force, my momentum kept going forward.
If he'd have been a less powerful athlete, he probably wouldn't have had that kind of shearing force to his hip joint. And he would have gone down in a tackle and he would have been fine.
And Walker, as he made the tackle, had only the one leg to grab, and apparently Bo Jackson shaken up a bit, if not got to his feet as yet.
The Royals were full of hope, of course, at the time that he would be able to recover from that and go on to play. But as time went by and it became more and more obvious that he wasn't going to be the Bo Jackson role, it was a very difficult decision to let him go.
I would like to be in that body just one day and play baseball, just to see what it's like to run that fast.
When he sport that Bo competed in, he was pretty good. Bo Jackson was a man and a half.
Yes, he did! I don't believe it! He made an absolutely perfect throw!
So let's start playing. I'm the Raiders. I'm Bo Jackson. You're pressing B. I'm pressing B. He's too fast. Going over here. Going over here now.
Bo Jackson also played professional baseball.
Shut up, Joe. Everybody knows that. Good touchdown. Yeah. I won the game. And now I'm going to jump Bo Jackson.
Alright. The key things in there. Reynolds was out. If you follow sports back then, Reynolds was out, the guy he threw out. And then I've often heard of what he said, I'm not exactly sure. And when he's throwing his helmet, it wasn't that he was disagreeing with the call, he was saying the throw was impossible. Somebody did one of those recently in baseball. I don't remember who it was. Anyway, y'all saw, the 30 for 30 even goes more into with the doctors and stuff about how he actually dislocated his hip. But that was Bo Jackson. If you never met Bo, there he is. We'll never know. Because it's got to be a sad thing. You never know because, you remember they kept saying, he's a Hall of Famer in 2 sports. He's going to go to the Hall of Fame. You got to do a whole career. Sorry, you ain't getting in. Pete Rose is going to get in now. Or is he already, he's in now? Did he already vote in? Y'all aren't. What are y'all doing? Like studying too much? Y'all aren't following this stuff? Pete Rose had to die to get in. Golly. It's true, right? Well, he bet on his own team, so. Alright, too long of a digression, I get it, but I was, originally I brought that up and I only cut a little bit of it out, just to show how the injury occurred. And that's a unique way to do that, because a lot of them, if you're gonna see one, it's generally an auto, not somebody holding you down. Alright, superior gluteal nerve injury. There's nothing special on mine, the instructor's not either, it just makes it small. Superior gluteal nerve injury, so we're talking about a nerve injury that's going to affect the gluteals, and it's going to have you develop what's called a gluteal gait. So remember, superior gluteal nerve innervates gluteus medius and gluteus minimus, which we said functions like the deltoid. One of the big actions of the deltoid, especially once you get up even higher, is to do abduction. So you're going to see a characteristic loss with a superior gluteal nerve injury, you're going to have weakened abduction of the thigh. Mainly, it's associated more with gluteus medius instead of minimus. But so this gluteal limp that you're going to develop is because you can't hold your hip up anymore. So if you look at A, we have three slides here, but A in this picture, you have the tops of the iliac crest should be even. So if you're standing up straight like an anatomical position, they should be even. But if you lift your foot, the opposite side has to erect, has to compensate. So in the second picture here, B, you have active gluteus medius. It's working just fine. So as you lift this foot off the ground, this muscle is going to tighten to hold this side up. Makes sense? So that you're standing there, and if you lift up, if the muscle on this side is not working, you're going to come down. Because this, you picture it pulling this way, right? I'm up, it's going to straighten me back up. So we don't notice that because we don't have that problem. But somebody who had a superior gluteal nerve injury would. Then you go to C, and this is what's called the positive Trendelenburg sign. When they lift their foot off the ground, the hip's going to sag on this side, which means the muscle that's damaged, or the nerve to the muscle that's damaged, is on the opposite side. So Trendelenburg side, superior gluteal nerve injury. Link those two together for physical exam. This is one of the things that they talk about. Alright, now we're not studying plexus, but we're getting down to the area where we talk about the nerves of this lower extremity. The tibial nerve and the common fibular nerve are the two components of what's called the sciatic nerve. Now, the sciatic nerve comes off the lower lumbar and sacral spinal nerve roots, and then it makes that nice big sciatic nerve. And shortly after that, that sciatic nerve is going to split into common fibular and tibial nerve. So we start to see this schematic where we have the sciatic nerve coming out up here. We find it in this block. That's going to divide into the tibial nerve and the common fibula. The tibial nerve is going to run down the back side, the posterior side of the leg, the same as the radial did for the upper extremity. So all of our posterior compartment muscles of the leg, lower extremity, thigh, will be innervated by the tibial nerve. So that's a commonality that helps out with studying. We'll get down we'll see this part again, but I'll mention it here anyway. Medial and lateral plantar nerves come off of the tibial nerve at the foot, basically. And then the common fibular nerve divides into the deep fibular and superficial fibular nerve. So those are all the nerves that are going to be innervating our muscles down here in the lower extremity. And the sural nerve is stuck here because it runs up the back of the calf. So I wanted to talk, I already kind of talked about it, but this probe, follow the probe all the way in, it's actually holding up the sciatic nerve. So when we look at piriformis as it's coming out of here, if that gets tight, you get piriformis syndrome. And not only that, some people, and I'm starting to wonder if I sure hope I'm right about my diagnosis, I could be dying, but I'm here. Just like I was talking about entrapment, some people, whatever percentage there, have a sciatic nerve that part of it goes through the piriformis muscle. So when they get piriformis syndrome, that piriformis gets tight, it's going to really hurt. But it's close enough to the muscle and the nerve, the piriformis muscle and sciatic nerve, close enough together that just sitting for long periods of time can get that muscle tight. When the piriformis gets tight, you will start getting like some mild sciatic type symptoms in the leg, which are easily relieved with just stretching that muscle. You just have to know how to do that. So you get all these symptoms: buttock pain, sciatic symptoms in the leg, can be dermatomal. You don't have to remember, we're not doing diagnosis and treatment, but just put it there for reference. And so you get this dull ache. It's kind of in your buttocks, like the dimple of your butt, as we say, and it kind of goes down into your leg. Make sure your leg feel kind of dull and kind of heavy and aches at the same time. Anybody ever had that while they're driving? I don't know much how I drive for an hour. I don't stop. But you need to get out, walk around, stretch that out. Treatment, stretch. I've never met anybody that actually had it surgically released. Could you go in there and release the piriformis muscle and be all right in life? Yeah. We got a lateral rotator. We have other lateral rotators. So if they have somebody who had the sciatic that went through that muscle, they could go in there, kind of cut that loose and allow you some relief. But most of the time it's handled with exercise, stretching, trigger point injections, whatever can cause that muscle to release. So we already know we get our gamma globin, those types of things, because we're all military or ex-military. So the gluteal region is a common site for intramuscular injections, but it's not like watching they do on TV where you're just like, I'm just going to just dart somebody in the buttocks there, because now we know that the sciatic nerve is lying in there. So when you give a gluteal injection, you do not just find that nice big gluteal muscle and stick that in there. There are actually landmarks that you need to look for, and essentially, if you drew a line extending from the posterior superior iliac spine across to the greater trochanter. The greater trochanter is that bony side of your hip, like when you lay down. Drew a line across there and kind of divided it in half. You actually want to give the injection in this green area, not down here in the buttocks. If you go down there in the buttocks, just be ready to duck, because they're very close to you, right? And you stick that in there, because I see an elbow's coming. That's going to hurt. Just in case you didn't know that, that's where you actually do the injection. And there's plenty of meaty muscle flesh up there. Alright, so the thigh. Observable features of the thigh. When you look at what we call our quadriceps group, they're divided up into 4 different muscles. You can only see 3 here. You have vastus lateralis, and then you have vastus medialis over here, and then rectus femoris, which is in the center, essentially coming down. As we go along more, we'll start to annotate some of these. I drew arrows for you. Once again, lateralis, medialis, here's lateralis, medialis, and then rectus femoris in the center. Deep to those, there's also a vastus intermedius. That's why there's 4 of them. You just can't see it until you reflect them, or reflect those superficial muscles from them. Another very long muscle in the lower extremity is sartorius, and sartorius comes lateral to across the thigh. It's often called the Taylor's muscle. That would get strengthened the way they sat for some reason. So the most lateral structure of the thigh is the iliotibial band. We said that we had the gluteal muscle, gluteus maximus, is going to insert into that gluteal band that we have there. And so gluteus maximus inserts into that, and that makes this the most lateral portion. So that is the iliotibial band, and it goes down and actually inserts below the knee. So the reason we focus in on that is not only do we have ITB band syndrome, where it's tight, but the iliotibial band is the most lateral structure, and the key to that is it's helping to stabilize the lateral side of the knee. Remember, the knee needs a lot of, sorry that sounded funny, the knee requires a lot of stabilizing muscles and ligaments. And so that lateral structure will do that. So here's my general characteristics that I like to do. Here's our compartments. We have an anterior compartment, we have a medial compartment, and we have a posterior compartment of the thigh. The anterior compartment are going to be a little different than the upper extremity. Remember, in the upper extremity, when we had an anterior compartment, it did flexion and flexion. But the lower extremity doesn't function the same. They do an opposite action at the hip and the knee. So the anterior compartment of the thigh does extension at the knee and flexion at the hip. And almost all of these will be innervated by the femoral nerve. So I will point out the exceptions, but almost all. The medial compartments are adductor group, and almost all of those are innervated by the obturator nerve. And then you have the posterior compartment, which is our hamstrings, and their actions are to do hip extension and knee flexion. And they're almost all going to be innervated by tibial nerve. There's not a whole lot of exceptions, and I just can't say all of them, but you can pretty much generalize all of them in these nerve groups. Anterior compartment's probably going to be femoral, medial compartment's going to be obturator, posterior compartment's going to be tibial. Right? Remember, tibial came off at the sciatic, so sometimes you'll see that like a hamstring muscle is innervated by the sciatic. That's true, but it's tibial division. Let's go through this slide, then we're going to cut and come back. Anterior compartment, here is the list of all your muscles in it. Pectineus, iliopsoas. Remember, iliopsoas is a combination group of muscles of psoas major, psoas minor, and iliacus. Sartorius, you have quadriceps femoris, or that group of muscles, right? And then tensor fascial lata. We're going to go through each one separately. There's your anterior compartment. If you want out here, for the most part, you would be correct saying they're probably all innervated by a femoral nerve. Posterior compartment only has 3 muscles we got to worry about: semitendinosus, semimembranosus, and then our biceps femoris, not brachialis. Biceps femoris, which is a thigh muscle, posterior compartment. And then the medial compartment is our adductors. So you have adductor longus, adductor brevis, adductor magnus, and then they throw in gracilis, and gracilis happens to be the most medial muscle of the thigh, if you're looking at images. Right. So grouping all these together and just giving you a reference, this is tensor fascial lata, which job is to put tension on the fascia there. If you follow sartorius coming across, right, we can see vastus lateralis again, vastus medialis, our rectus muscle here. You have gracilis that's hanging out, that most medial portion of the thigh. Pectineus, and then iliopsoas comes down in here also. All of these, pectineus and iliopsoas is the floor of the femoral triangle. So we'll go through each one of them individually, but that's the overview of how the thigh looks. And why don't we take a break? Sorry, killing you all. Sorry.
Just a memory of what it was.
I was like, what is this? How's it smell? So I put a bottle of vinegar. anyone. They're all competitive. Yeah, someone's trying to swap them. They're also not trying to I guess the extra just the not they'll be out something. I'm just here like I was looking at like I was going with like make sure like stuff like the make sure like when we do the topic the last one part of it is having our subtitles on. Maybe we didn't know that and we just forgot it. Like I feel like we were doing that when we first doing it. Yeah, like you don't look up and then you press into it. I didn't really realize that. So maybe
Yes, sir. Can we help you?
I am, but maybe
I do that for Officer Members.
This is LT.
there was a memo came out saying that they would never be spared in these specials, so because you have a mustache.
Let me see this mustache. Nope, going over the limb. The more you move, the more
He's like, hold on, let's cover it.
I know the game. How's that first started? How's that?
Yeah, looks good, right? Good, right? Gotta go. For the record, it sounds right.
I said the issue about the
Yeah, I'm getting like all the things that I do. We start off with.
I feel like I'm
I don't think they're going to do the little things. Well, I think here's the issue. Because he smells like ass.
me still that like you know like what happened is the one they call it. I would say I would call it
remember, he was great. You got 20 hours a day. You get out of work. I did it.
Well, the most.
Y'all were great this semester?
Right. After the appointment at 3 o'clock. You can just get that.
Big time now.
Is there like a go sign was great?
That's one of our tiles in our. So we'll share the time.
It's a bit different. The way how you then you went back to while they were sticking
She's not my boyfriend.
but he really focused on pronate. I don't get taste. And then keep on in your spot.
That way you can.
The areas that might be the most steeper is thinking, what do I do? It's not the action, it's just like you're just going back and forth, up and down, and then extra quick, but like just to remember like business. So you should think about it, that's fine.
And you'll get just show them. It's kind of fun.
I'm gonna be like, hey look, just follow my lead. That one, yeah, kick it like a free hand, back to center, forward, back, left foot. Yeah. I don't do that like half a brain. This is a whole new one. This is how I've seen it done. This is how like So when you lay back, no, because lay back and reflection itself more than just so that's why you can also do that. But then they have to like and then they get so there's like 85 spots here.
Second time, same deal.
What song starts out with that? You guys say a little bit. Let's do it. Anybody know? 80s. Also saying you got head fever or something. knows who Tone Loc is? You're making me think my condition right now is messing with my mind or something. Funky Cole Medina. Okay, forget it. Forget I brought it up. Anybody know who Eazy-E is?
Yes.
Okay. He jumped right to that one. Okay, here we go. Tensor fasciolata. When we looked at landmarks on the ilium especially, we pointed out we had the anterior superior iliac spine. And that's it as an attachment point, really an origin for, we're talking about that bony part that's about at your belt line for males, that bony projection, and that is where sartorius originates, but also this muscle, tensor fascia, which, just like its name says, its action is to tighten the iliotibial band, a lot of what it does, but because of the way it's set up, it gets all these different actions that is not a big player in these, but it can help flex, abduct, immediately rotate the thigh. And then it throws in there, it's stabilizing the knee joint. Remember, the iliotibial band is what helps to stabilize the lateral side. Did I say medial? The lateral side of the knee. And so tensor fascia and your gluteus maximus both tie into that and make that very thick band that is going to insert down below the knee joint. And it's right there by our gluteals, so it also receives superior gluteal innervation, nerve innervation. We have no shortage of muscles today, if you can't tell. Pectineus. Remember, we're in the. I didn't put a title slide there. We're in the anterior compartment muscles at the moment. So pectineus is a very small muscle, and pectineus sometimes is considered a transitional muscle between the medial and anterior compartment. But I just decided to leave it for us in the anterior compartment. And so the anterior compartment, because it receives femoral nerve, it originates off of the pubis and then inserts along the line of the femur. If you drew the line of the femur, you've got muscles that will attach there. And so it actually inserts here. Good to know because that's what shows us that it helps to adduct the thigh and flex the hip joint. If we look at sartorius, remember it's coming from laterally up here on the ASIS to medially down below the knee and inserting here. So it goes across the thigh. Now this insertion point is one of those I want you to pay attention to. It's a little more unique because we're going to have a slide later that lists three muscles that are part of what's called the Pezan-Serine group. And they are important because those three muscles, that one comes from each compartment of the thigh, they tie in together in what's called the Pezan-Serine, and it helps to stabilize the medial side of the knee. So sartorius can flex, abduct, and laterally rotates the femur at the thigh. And it is also femoral nerve. I know we already discussed psoas major minor iliacus, but here's their actual full slide again. So you have iliopsoas where we have psoas major and minor originating off of the transverse processes. The iliacus portion is going to originate in the iliac fossa. And then all of them are going to insert into the lesser trochanter of the femur. So because this muscle comes off of the vertebrae, it can help with flexion of the torso and the thigh, or it can help to rotate the thigh laterally. Right? So if these pull, it's actually going to rotate this towards the outside laterally. Now it has two different innervations because if you want to separate them in your mind, think about that the psoas major and minor originate by the spinous process, by the vertebrae. So that's where they get their innervation. But iliacus is down closer to the thigh. And so you can almost think of iliacus, specifically that portion being in the medial or anterior thigh because it has femoral nerve innervation. Just two different ways they talk about it. Are you talking about them in a compartment form? In that case, I'm going to try and clear up what I just said because I didn't think it was clear. When you're thinking about nerve supply, are we talking about muscles that are associated with the hip, or are we talking about muscles that are associated with the thigh? And you can separate them out and say, well, iliopsoas is a group of muscles, and they like to group them all together like that because they're a common insertion. But if you go and say, well, I'm going to talk about compartments, okay, well, we can separate out psoas major and minor as being part of the hip, right? It's not it's extrinsic. Iliacus would be intrinsic. So a lot of times iliacus, you just visualize it as an anterior compartment muscle. I still don't know if that was any clearer, but there's also an Excel sheet where you can study these. Not even a smile, am I good? I know it's me though, that's alright. Alright, let's look at the quadriceps group. Vastus lateralis originates greater trochanter, line of femur, inserts this muscle here. It's going to insert into or at the tibial tuberosity. So if you look at things like pervascus swatters, all of these four muscles of the quadriceps group will insert into the tibial tuberosity. And it says via, there's a patellar tendon there. So really when you look at it, and don't key in on this, I'm going to say it anyway, but tendons attach muscles to bone, right? So what connects a bone? Ligament. Okay? So technically, not technically, factually, in anatomy, we don't always refer to it, because what do we call it when we hit, let your hips go. What do we call it when we hit patellar reflex? Patellar tendon reflex. The quadriceps group all comes down and all of their tendons insert, not really insert, but connect to the patella. So really the patellar tendon is here, where it's coming to the sesamoid bone there, patella. And going from the patella to the tibial tuberosity, that's more of a ligament. And some people try to divide it up that way, but that's technically, you can't say that because the patellar tendon is one intact structure, and they do label them that way. But what's the definition of a sesamoid bone? A sesamoid bone is a bone that grows within a tendon. I'm talking about things that if you get into anatomy circles, people will talk like that about that. And at the end of the day, I always go back and say the same thing. Well, what do they call the reflex test? Patellar tendon. Okay, so we're going to call it a tendon. Bringing y'all into these, the geek conversations between anatomy people. The main point here is all of your quadriceps group will combine to become the patellar tendon and insert at the tibial tuberosity. Okay, vastus medialis. Whoops. Vastus medialis over here. It's going to do the same thing. Originate off of the femur, insert into the patellar tendon, ultimately to tibial tuberosity. And I didn't say it on the last slide. They're all going to be extending, right, the leg at the knee. They're going to be knee extension and they're all femoral nerve. Intermedius that I started to draw a second ago is deep to that. Did I skip a slide or something? Rectus femoris. The only thing to point out on rectus femoris is out of all the quadriceps, where do them originate? Off of the femur. But rectus femoris originates off of the AIIS, which means it crosses the hip joint. So rectus femoris can help flex the thigh, and it can also help extend the knees. The other three quadriceps muscles can only help extend the knee because they do not originate above the thigh joint, okay? But they are all the same innervation, femoral. Then we look at the posterior compartment of the thigh, what we call our hamstrings. In general, most of their origins come off of the ischial tuberosity and are going to insert somewhere on a tibia or fibula. So that means it's going below the knee joint. And all of them are going to be innervated by the tibial nerve. There's only, I don't want to get there. So here's our hamstring muscle: semitendinosus, semimembranosus, biceps femoris. Don't worry about long head only. Part of the adductor magnus. That's going to be something we got to discuss. It's a little different. Adductor magnus is a medial compartment muscle that has a portion of it that is considered posterior compartment. And the reason we're going to point it out is there's a big reason why that has to occur. Okay, so let's look at biceps femoris. We're looking posteriorly now. So it's originating off of the ischial tuberosity. And then it has a short head that comes off of the shaft of the femur there for its origin. And then it's going to cross the knee, so we cross the hip up to the top, and then we cross the knee and insert right by the fibular head, right in the lateral portion of our tibia. When we look at the action, that means that this can help to extend the hip joint and flex the knee. Just the opposite of what we saw with our quadriceps. Our quadriceps extend the knee and can flex the thigh. Our posterior compartment muscle, our hamstrings, can extend the thigh and flex the knee. So they're doing exact opposites of the anterior side. The innervation for biceps femoris, technically this is one where you would more likely say sciatic because it receives tibial and common fibular. Just so happens that right as it splits, right as the sciatic nerve, as it comes out, splits into common fibular and tibial, it innervates these right at that point. So they separate them somewhat. You can just, when it comes to posterior compartment muscle, in that case, you can just say tibial. Right. Semitendinosus originates off the ischial tuberosity. It's the second muscle. Now we have two. We had sartorius. Now we're going to add semitendinosus. Makes an insertion on the medial side of the knee at the pes anserinum. So its job: extend the hip, flex the knee, and it is tibial nerve. Then we have semimembranosus, also originates off the ischial tuberosity. Now this one's going to insert in the medial part of the tibia, but doing the same action and same innervation. Extend the hip, flex the knee, and it is still tibial nerve. At this point, you should be starting to see even more and more why you should be happy you don't have to learn every origin insertion. Because there are a lot of unique things there. Okay, now we switch and talk about the last compartment of the thigh, the medial compartment of the thigh. General origin of these muscles are going to be on the pubis, and they're going to insert into the femur along the line of the femur. Remember, these are adductors. Innervation for this compartment is going to be obturator nerve, and we're going to focus in. Some of these do some rotation type things, but they're adductors. So the action, for the most part, is adducting the thigh at the hip joint. So you have adductor longus, adductor magnus, adductor brevis, and then you have gracilis. You notice pectineus is here.